this space in Fiji. Rosa?
No, this room is quite small. I wonder whether we really need a microphone. But good afternoon. Yeah. And welcome. And I hope this is obviously the penultimate session of a two-day conference, and I hope that you've all enjoyed and learned from this. And learned from this Pacific Update Conference, the title of which is Inclusive Growth for Enhanced Resilience. And I think this is the only health part of the whole conference. And we heard in the opening remarks that people are the most important part for any country's development. And obviously for us in the health sector, without health, then it is a challenge for people to be able to work, produce, and really attain their full capacity, especially in the development of our countries here in the Pacific. So this session we have 4 speakers, and their bios are there in your meeting notes. But basically, it focuses first on NCDs, obviously a crisis for all of our countries. And so we're going from a regional perspective with Dr. Paula Vivili from SPC to start off. Then we move to more nuanced sort of, hopefully Dr. Masoud will come, really looking at economic analysis of it, because obviously as a crisis, therein also lies a challenge for all of the countries to address this crisis. So then Dr. Masoud will talk, followed by Dr. Wayne Irava and Idrish Khan, really looking again at financing aspects of NCDs, but probably more broadly, Wayne and Idrish, how a country's finances can really influence the way that the countries approach NCDs. And then we have Ravi, who will more or less round it off and really looking at the planning aspect and how NCDs can really fit into a country's planning and things that we can learn. So welcome to this, basically the penultimate session of this conference, but it's not the least important one, I'm sure. So please, we'll have the speakers go one after another, note your questions down, and then we'll have a panel discussion for questions afterwards. So thank you, welcome, and I welcome Dr. Paula. Maybe just hold it.
Thank you very much. Rosa was my tutor at school. Although I have more white hair than Rosa, it's a pleasure to be here today on behalf of the Pacific Community SPC to give this talk on the outcomes of the Pacific NCD Summit. You know, the Pacific is full of small islands. Papua New Guinea perhaps not such a small island, but big challenges. And I was thinking, I had a look at the program, and we were the second last program. And I was wondering whether this reflects the importance of health that the organizers placed on this issue. But it reminded me of one session I went to. The last session, the speaker said, it may be the last session, and it may seem to be the least important session, but it's the session that people usually remember, because it's the last session, or it is the penultimate session. But nevertheless, In the Pacific, we know that there are many, many different challenges. You know, there's climate change, there's economic issues, there's education issues, NCDs, renewable energy, and many, many other challenges. But really, when you look at it, as Rosa alluded to earlier, if the people are not healthy, then you'll struggle with all of these issues. And if you have a look at these, just to give you a snapshot of the state of health in the Pacific, not such the healthiest population by far if we look at these indicators. So it's no secret for overweight and obesity. If you look at the top 10 in the world, it is actually from the Pacific. You read the reports, they say it's top 7 or 8 out of 10, but if you count all the countries that have done surveys from the Pacific, it's actually the top 10. So out of the top 10 biggest nation in the world, you get the 10 of them from the Pacific. If you look at diabetes, diabetes is also a reflection of non-communicable disease in the Pacific or in the world, and the figures are not particularly flattering. And the bottom line is 6 to 8 people out of every 10 deaths in the world, in the Pacific, is from non-communicable diseases. And sadly, we're seeing more and more people getting younger and younger as the years go by. So in some countries, the life expectancy used to be in the 70s. Some reanalysis of the data is indicating that they're actually dying in their 60s. And just to put things in perspective, some Pacific countries, the life expectancy is still in the 50s. And with NCDs expected to make life expectancies lower if nothing is done, then the future unfortunately does not bode very well for health and consequently for other issues. Just a slide on economic burden. World Bank did some work on economic costs, and this will probably be covered by some of the speakers speaking later. One country in the Pacific already cannot afford to check cholesterol, nor can give drugs for people with high cholesterol in this country. The drug cost for one patient, for treating one patient with diabetes, equals the drug budget for 76 people. And if 1% of the total population is treated with insulin, that's the total pharmacy budget used. So from an economic perspective, it's already unaffordable. It's not something that's coming in the future, it's something that's already here. In another Pacific country, where they do dialysis for people with kidney problems, it's costing about $40,000 per patient per year. This was figures for 2010-11. And this is more than 12 times the gross national income per capita. In 2 years, 2 out of the 3 people that were on dialysis have passed away. So the costs are significant, and not just, and this gives you a cost on the government. But we're not discussing social costs and costs on the individual, family, community, churches, and life. Many of you are involved in health, and you will know that there hasn't been a lack of declarations and commitments. There's many of them. And so we cannot fault leaders for not giving this due importance. And even at the Pacific Island Leaders Forum, this has been brought up and considered to be an important issue. Just to highlight one issue that had been put forward by the leaders, and this is the Pacific NCD roadmap. This was the result of the first ever joint meeting between the Forum Economic Ministers and the Pacific Health Ministers, which was done in 2014. And this was the first real effort to look at the multi-sectoral approach to addressing non-communicable diseases. And this focused on 5 key areas, as you can see here. And many of you are familiar with the NCD roadmap, so I won't go into it further. Since it came out in 2014, there's been some reviews of how the implementation has been done. And it's been noted that there's been considerable actions. However, much more needs to be done. The action to date is not commensurate with the burden of non-communicable diseases. And I've just put here a few things that have been done related to the NCD roadmap, just to give you an idea of how things have been. So out of the 22 countries, 7 countries have increased taxes on tobacco. And there's a target of 70% of the retail price being a tax. 2 countries have attained the targets. So some things have been done, but 2 out of 22. So that tells us that while a lot's been done, we need to do more. If you look at unhealthy food and drink, 3 Pacific Islands have increased taxes on sugar-sweetened fizzy drinks. And some countries have also taxed other issues. But really, just to show that while some things have been done, we really need to be doing a lot more. I mean, we take us back to the critical issues. Despite the fact that we know that we need to do these things, at the end of the day, there's other challenges. It's climate change, economic education, and we have to make a choice of the things that we need to do. And hopefully, as a result of the discussions we have, non-communicable diseases and health feature a little bit more. So it was decided that there be a Pacific NCD Summit. It's actually the first summit that's been carried out in the Pacific. And discussions between Pacific community, co-hosted by the Tonga government, Australian government, New Zealand government, the US, UNDP, World Diabetes Foundation, and World Bank and World Health Organization. We were very fortunate. King was able to be there and open the summit. The President of Kiribati, Prime Minister of Tonga, and Helen Clark delivered administrator for UNDP delivered the keynote address at the opening. So the idea for the summit was to present a more case for more urgent and stronger action at high political level to address the NCD crisis. Review how Pacific Island countries and territories were implementing the NCD activities aligned with global and regional commitments. To accelerate the progress on the implementation of Pacific NCD roadmap, as I just alluded to regarding the progress. And to create and develop opportunities for South-South collaboration in implementing good practice to address non-communicable diseases. So the structure of the summit was on day 1, there was focus on global issues. So Helen Clark focused on the Sustainable Development Goals, which, as many of you know, has now included health and in particular non-communicable diseases as one of the targets. This, of course, had been a criticism of MDGs, was that the fact they focused a lot on HIV, AIDS, malaria, and TB, but did not mention specifically anything about NCDs, despite the fact that most people were dying from NCDs. So day 1 focused on global issues. The WHO Commission on Ending Childhood Obesity and some other global issues were discussed on day 1. Day 2, a lot of time was spent on looking at the implementation of the Pacific NCD roadmap. And day 3 was a focus on diabetes, because for many Pacific countries, diabetes is really what people associate and see as non-communicable disease. All in all, there were 19 outcomes from the summit. I'm just going to cover a few of the key ones, but obviously happy to discuss others if people wish to see. As you saw from the objectives, the first one was really about political commitments. And at the meeting, the leaders committed to urgent and stronger action at highest political level to address the Pacific NCD crisis in the context of new Sustainable Development Goals and the Pacific Healthy Islands Vision. Many of you are aware of the Pacific Healthy Islands Vision, which was the vision that was put forward by the Ministers for Health at the inaugural meeting in 1995. And this was recommitted to by the ministers last year at the 20th year of Pacific Healthy Islands Vision. So the first, importantly, the meeting agreed to commit to more political commitments. One of the key things that was desirable before the meeting was to have some discussion on accountability. And after the discussions at the summit, it was pledged to establish and commit to timelines at the national level to implement the key recommendations of the Pacific NCD roadmap. One of the issues with the roadmap was, despite the fact that it gave out the recommendations, it didn't give a timeline, or it didn't commit people to agree to do this by a certain time. So as we saw earlier, after 3 years, 2 countries have done some things. So at this meeting, there was this good discussion and agreement that there be commitment to timelines, including quantified and measurable targets to achieve the roadmap, recognizing previously agreed global and regional targets. On monitoring, evaluation and learning, it was agreed to strengthen data collection and health information systems. It's a struggle of information systems in many Pacific Island countries. And so one of the key areas during the summit was discussions on how this can be improved and strengthened. In funding, it was recognized that funding for non-communicable diseases, as you saw earlier from the quick example we gave on economic burden, that the funding for NCDs was not commensurate with the burden. So the meeting called on governments and development partners to invest resources to address NCDs, particularly including childhood obesity priorities. Many people working in NCD feel that the current generation, we probably should give up hope on them. So for those that are here, the view of some is that, oh, we'll forget about them. Let's concentrate on the next generation because we might have a better hope with them. Nevertheless, there was support for proposal to create a Pacific funding mechanism, be it regional, bilateral, or national. And there was an aspirational goal to raise 100 million to help address NCDs by the end of 2018. On tobacco control, quite a lot has been done in this area by countries, but there was commitment to introducing and strengthening national legislation to ensure that all Pacific countries are compliant with the FCTC. FCTC was something that came about in 2004. All Pacific countries committed to it in 2004. But 12 years later, many of them are still trying to implement the clauses as put out by the FCTC. There's also a commitment that was done in 2013 in Samoa and agreed to in 2014 in Solomons that the Pacific would be tobacco-free by 2025, meaning that the prevalence of smoking in countries would be 5% or less. Still a long way to go to reach that target, but nevertheless been agreed to by the leaders. On trade, many in health feel that without addressing trade, we might as well just stop everything and go home. And during the discussions in the meeting, because trade plays such a big role in non-communicable diseases, it was requested that PIFs and other partners provide an analysis of trade and its impact on health. Many people know that some Pacific countries have worked on banning turkey tail, and before joining WTO, were asked to repeal the legislation. Or wanting to ban mutton flaps, and before joining WTO, were asked to talk about that later. So trade is an important issue, and it was one of the first steps in doing this is having a better look at it, is requesting PIFs, who actually is the organization that looks after trade, to better look at these issues. Diabetes, obviously, pledged to focus on resources, on cost-effective interventions, and looking at different aspects of diabetes that works in some countries that could perhaps be translated into others. Just to finish off, positive change is possible. So if we look at data from Samoa, we've done 2 surveys to look at NCD risk factors from 2002 and 13. You can see that it is possible to change in a positive manner. And you can find data like this for countries that have done 2 surveys, namely Fiji, Tonga, and Micronesia. But really, it's not an impossible task. And just to finish off, the burden is clear, and we know that interventions work. So what we hope is we don't keep talking about the burden. We already know the burden. It's a big problem. We already know the interventions that work. We shouldn't be asking what should we do now. We already know what we should be doing. Progress to date has been encouraging, but much more needs to be done. Leadership and multi-sectoral collaboration is necessary, and this will be discussed to some extent by Ravi later. Accountability and funding, important issues, and it is doable. We just need to work together a bit stronger. Thank you.
We can have Dr. Masoud.
Yes. Hello, everybody. As you can see, my topic is about a systematic review study I have conducted to measure the cost effectiveness of non-communicable disease or NCDs in Pacific countries. I just reviewed the article which published about NCDs in different countries in Pacific islands, and I report my results. First of all, let's talk about introduction and background about this health issue. As you can see, WHO is different. The NCDs perform major health issues such as cancer, diabetes, heart disease, and COPD. But we can add some other issues such as dementia or mental health, and also injuries. And the main risk factors as well has been recognized as a 4 items, which are tobacco smoking, unhealthy food, physical activity, and using or consumption of alcohol. As you can see, NCDs is growing around the world. It's not up to developed country or developing country, but around the world is developing. But in poor countries is a big issue because there is no more financial support to, for example, do some activities against that. And as you can see, about 70% of global burden of disease is related to the NCDs, especially that for diseases. As you can see this picture as well, 1 person in 11 people are engaging with diabetes, and 422 million adults have diabetes, and 1.5 million people died caused due to diabetes. So we see this is an example which shows NCDs is one of the big issues around the world. We want to talk about the Pacific area. What about the Pacific? You see, NCDs again can be considered as one of the challenges, health challenges in Pacific countries as well, and in different countries, and 70% of all diseases can be related to the NCDs in Pacific country. If you see these tables, it shows different items has been measured in 2011, WHO reported, which NCDs as percentage of all these in different countries. You will see Fiji about 77%, and smoking as well about 8%. And you can compare which is risk factor are very huge and also very important in different island countries. Let's go to the next slide to talk about mortality percentage. In total deaths in 2008, which calculates were about, as an example, 3 countries are reported here. 37% in Samoa, 38%, 36% because of the heart disease. And you can see, you can compare, this is a big issue, non-communicable disease in different countries with huge number of percentage. So we can compare diabetes as one of the big NCDs in Pacific country, and especially in Fiji. You see It's growing from 1970 to 2020, and it can be different even between different ethnicity and also different genders or ages. But the important point is it is growing up, and we need to think about that. What about the relationship between the cost and NCDs? Many developing countries engaging with NCDs, and usually, as I mentioned at the beginning, in developing countries or countries which are poor, it is a big issue because they don't have good resources to do some activities against NCDs. And also, in the project, as you can see, 84 billion of economic production would be lost from heart disease and diabetes between 2006 to 2015. In 23 low and middle income countries, accounting around 80% of chronic disease mortality. To compare, for example, what amount has been paid for diabetes, for example, we can compare two countries, island countries, Solomon Island and Norway. You will see the national payment is about 12 million Australian dollars, and for each person is 281 in Solomon Island, and that is about 1 million for Norway, which is cost about 747 per person. Shows the cost is very high for prevent or for even treatment of this issue. And the cost of diabetes based on people who are engaging with diabetic patients is actually very high. In Solomon Island, you see about 4,000, which based on the person about $99, and for Norway about 173, which costs about 110 per person. So it's a big issue, and we need to think about that. What is the objective of this study? As I mentioned at the beginning, this is a systematic review. Just review the article to see what is going in this health issue, NCDs, and what we can do. What is the gap? Especially about considering cost effectiveness. The method I used, as I said, is systematic review. I reviewed different databases which were accessible in the university website, and I included the article which published in 2000 to 2016. They were peer-reviewed, and also they focused on NCDs. And I included all types of study, randomized controlled trial, quasi-randomized controlled trial, descriptive all the studies, and all the studies. And I used some terms to do search about these to find relevant articles. Some key terms were related to the cost parameters. You can see using this strategy I did research. For NCDs I used different terms to search. I include place as a Pacific, and the study design, as I said, I included all types of studies. And when I collected the final relevant articles, I reviewed the full text, first the titles, and then go to the abstract. I reviewed the abstract and full text, and finally found the relevant article which can be analyzed in the last step. And I just used the descriptive analysis to analyze these articles because there were not any too much randomized controlled trial studies to do meta-analysis. This is the diagram shows what was the steps I have conducted. I have done to reach the final article here. 58 articles. I reviewed the titles. Some of them have been excluded because of some methodological aspects, or their full text were not available. And in different steps from it, I think about 43 articles were published about NCDs in Pacific. Here, I just report my results. As you can see, most of the studies were published in 2011 to 2016, as I included about 2000 to 2016. and then 2006 to 2010, and the lowest number about 2000 to 2012. It may be because of the importance of NCDs, which when growing, most researchers are interested to do research about NCDs. This figure, this graph shows the frequency in terms of different countries which did research or they published articles on the basis of NCDs. As you can see, New Zealand had done the highest number of about 20%, and it's reduced to Djibouti, which had about two articles, and you can see Fiji had about 9.4% of the article about NCDs, which meets the inclusion or exclusion criteria of the study. This graph shows based on the kind of studies. As you can see, about more than 2/3 of the study, about 75%, were descriptive studies. It means they didn't do any interventional, and just RCT, you can see 9.3%, and 4.6%, 4.6 just did mixed into the studies. But the point is here, most of the studies are descriptive. This graph shows based on different age groups. Most of NCDs study focus on adults, and then older people, and then adolescents, and the few study about children. But we need to consider to prevent NCDs, we need to focus on adolescents or child at the beginning to prevent at the future. This graph, based on the location, is most of the study focus on hospital and health care centers, because maybe they engage with people who are coming to the issues they encounter, such as diabetes or cardiovascular disease and so on. And 34% is conducted on community-based studies, and 60% household-based, and only 9% in school-based. But my concern is to consider most of the studies need to be conducted in this part to prevent in future. It's based on the disease. As you can see, most of the studies conducted about diabetes, it means when I analyze, and then cancer, cardiovascular, COPD, mental health, and others. But most of the studies conducted about diabetes because of the risk factor and the importance of this issue, as previous lecturer mentioned about this issue. And this pie chart as well shows the risk factors. You can see most of these factors which have been analyzed are unhealthy food, 5 minutes. Unhealthy food about 35%, which and physical activity less about 20.9, tobacco 30%, or tobacco 20, physical activity 30, and just alcohol 13.9%. Means we need to do more activity, more research about these risk factors for future. And this based on the area of access, it means the study focus in NCDs, as previous lecture as well at some point mentioned. Lifestyle intervention, they mostly focus on that. Clinical service and driver, they did more study about this area when they work on NCDs. Environmental intervention, as the previous mentioned about the tax, putting tax for smoking out or something like that. Surveillance, advocacy, and community mobilization, based on the percentage I showed here. And for RCT, about 10% of the studies, as I mentioned, which conducted RCT and quasi-randomized controlled trial to study the result, highlighted that intensive lifestyle intervention to prevent NCDs is cost-effective in comparison to other interventions. So we need to consider this point as a policymaker in the future to help people, to educate them, to do some interventional study, to help people to change the behavior which can prevent some NCDs in future, which is cost-effective. Community-based interventions such as the non-personal intervention for tobacco use, physical inactivity, and unhealthy diet tend to have lower cost-effectiveness than many clinical intervention. And finally, cost evaluated from a societal perspective within 3 broad categories. When the interventional study were reviewed, they showed most of costs were related to the patient's cost, program costs and training costs. Yes, there are costs, but what you see in future will save lots of money when you want to treat these health issues. In the discussion, I mentioned here, but when we review, because I have about 3 minutes time, when we review the results, we need to we can find lots of things. For example, first of all, there is no interventional study in this area. Means we need to support researchers to do interventional study to compare different strategies to see which one is more effective, cost effective. Yes, this can develop policy. This can develop, for example, I don't know, information for policymakers. Can help them to develop, for example, strategies to prevent these health issues. We need to focus on target group, which can help us in future. If we focus on household studies, school-based studies, youngers, adolescents, soon we will prevent these health issues in future. Policymakers need to consider this one. For example, lots of the results are reviewed. So the purpose is here, develop interventions and develop research, can help policymakers to adopt prevention strategies, which focus on lifestyle changes, and as previous lecturer mentioned, doing some environmental interventions such as taxing for smoking cigarette, alcohol, something like that, and doing some effective intervention which are effective, feasible, and affordable, can prevent these NCDs in future. Yeah, that is the last sentence in which we need to help people to empower their ability to develop their knowledge, attitude, self-efficacy, to be informed about these health issues in this area, to prevent about the risk factor which they are engaging, and finally to have a healthy community which needs less, for example, cost to prevent in future. That was my presentation. Hopefully I finished the good time. Thank you.
Thank you very much, Masoud. I hear Wayne and Idrish.
Come and sit here.
I'll sit here. Sit here.
Thank you. Firstly on the NCD, this is a joint presentation. Firstly, it's by the Ministry of Health and by Fiji National University. So I will take the first session of the presentation while Dr. Rosalina will follow with the second half. So we're still looking at NCD, and our presentation is slightly not that different, but it's just looking at the cost component of the NCD. So our presentation focuses on the disease-based costing from the national health accounts. Now, our outline for the presentation is I'm going to give a brief introduction of the national health accounts, what is national health accounts, and the methodology it uses, and how the disease-based costing is done from this system of health accounts plus the national health accounts, and then followed by the results that we had in these national health from the national health accounts, that is the expenditure by different classifications of the ICD-10 and by various categories. Now, in terms of introduction, national health accounts is a military and evaluation tool. What it basically does is it looks or it tracks the total health expenditure for our country, the flow of expenditure. When I say total, it looks at the entire health expenditure done by the government, the private sector, including the development partners. So that's how it tracks the expenditure. It tracks the holistic picture of how much the country is spending in terms of health. So that's what national health account is all about. And the methodology that is used in developing these national health accounts is we use this framework, System of Health Accounts 2011 framework. And in the framework, when we develop these national health accounts, this is how we track the expenditure. We look at the flow. Where the money is coming from, who manages the money, what is the money used for, and what services is provided. So basically, the revenue sources, where the money is coming from, health providers, who provides the services, the functions, what services are provided, factors of provision, what input is required in terms of providing the health services, the capital cost, and the beneficiaries, that is the disease, which is by gender, age, and various categories. So in the National Health Accounts report that we have done, I'll talk more on the history of the accounts in the next slide. This is where we have captured disease-based costing, and we have also captured NCD cost in this disease-based chapter. So a little bit of history in the National Health Accounts before we move forward. These are all the documents regarding the National Health Account. So the document that is to the far left up, that was the first National Health Account that Fiji had produced. That was in the year 2007. For the year 2005, produced in year 2007. And thereafter then we had the second report, which was for the years 2007 and 8, then 2009 and 10, then we had another report of 2011 and 12. The framework is such that, there was a revision in the framework. The initial reports until 2010, which was a framework that was used for the year 2000, it was produced from that basis because it captures a certain level of information. It does not really go into a further extent. But in 2011, when we had this international framework of System of Health Accounts 2011, it captures extra things like provision, capital, disease, and so on. That's why we use the framework to produce the 2011 report. And then we went on producing a government expenditure based on the same framework. We had a 3 policy briefs being presented, which we thought that quite useful for the ministry to implement, because we had recommended some changes that had resulted from the results from the National Health Account. So it's more on evidence-based. The results that we have received, we have suggested for recommendations and changes. However, some changes have taken place while some are still ongoing. And then finally we have a report for 2011. It's not a final report, but the last report, so to speak. It was produced in 2015, and this was for the years 2011. So here you have a report for 2011 report. Here you have a report for 2011 to 14. What we have done when the time you produce, as you improve on your methodology, your processes. So what we have done, we went back and we tried to apply that into those years of data, and we have consolidated a 4-year health expenditure in this report. All these reports are available in the Ministry of Health website. So that's the website on it. Now, some of the results that you can see in the National Health Accounts. I won't go through all, but this is some of the results. Current health expenditure. The total health expenditure that is incurred or that has been incurred in the country in 2014, 310 million. Then we look at some other indicators such as what was the private expenditure as a percentage of the 310, which was 34%. Right? Per capita, out of pocket, this is the interest of many policymakers, even politicians as well. Out of pocket, how much people are actually spending. So these are some of the results that has been given to the National Health Accounts report. We look at the curative, the preventive care, and hospital spending. So these are some of the results that produced. The report has more information on it, and should you have time, please read, and then you will get to know a more holistic picture. Now, coming back to the methodology for the disease-based cost under the SHARP 2011 framework, where our presentation is more focusing. So when we did the disease-based costing, we had used the curative healthcare which is approximately 40% of the current expenditure. Now, while we were doing the disease-based expenditure, we used the International Classification of Disease, ICD-10. I'm quite sure most of you are familiar with this ICD-10 classification. So what we did, when we looked at the expenditure, for example, if we look at the expenditure in the ministry where there is a program for disease, for example, TB control program, we took the expenditure for that particular program and we had directly coded into the appropriate ICD-10 code. So there are some programs in the ministry where we can directly code into the ICD programs. Another one is like, for example, dengue, leptospirosis. As we have programs, we have to go. However, when there is no direct programs, then we have to use some sort of methodology in distributing the cost by those diseases. And for the ones that were not coded directly, we used allocation keys and we have developed the methodology using the patient utilization data from the ministry and the patient information system, the BGs, the number of days, average length of stays, and also using the primary diagnosis. So most of our diseases, the expenditure that is coded in this ICD-10 category is mostly on the primary diagnosis because it's coming out from the patient information system. Now, this is the ICD-10 classification, and you can see that some of the classifications are in red. These are the ones largely related to the NCD diseases. So these are the ones. And I shall now invite Dr. Irava to run through the results that we have through this national health accounts program.
Thank you, Idrish. I'm not feeling very well today, actually. And when I walked through the door, the look of this room made me feel even worse. Okay? So perhaps a suggestion to the organizers for the next specific update 2017 conference, health needs a better venue. It is much more important than to place us in this small room, okay? Can I just go back a step to Idrish's presentation? So the disease-based cost results we present are just 40%. So you would ask us, well, 40%, what about the other 60? Certainly your results are not very trustworthy. You're dropping 60%. 60% is capital, which is about 12%. It's administration expenses, which is about 25 to 30%. So when you add that up, okay, you're not really missing much. Administration expenses is like the minister's salary. What portion of his salary goes to what disease? Very difficult. Including capital projects, infrastructure, the new hospital in Lavua. How do we divide that capital cost into diseases? That's still work in progress, okay? But for now, we've just gone with curative, and when we talk about curative, we're talking about inpatient and outpatient costs, largely. The red ones you see are largely NCD. They are not all NCDs, okay? Remember that, they're largely NCDs. We'll see why. Come on. So these are the results, and I know it's difficult to read from there. We just highlighted the yellow ones, okay? But let me just summarize them here. The results across 2011-12 and 2013 and 14 are not quite comparable because 2011 and 2012 is only inpatient expenditure. 2013 and 14 is inpatient plus outpatient expenditure, but it also includes outpatient expenditure from the private sector. And one of our limitations in the end of this presentation, we mentioned private sector. What we've done here, there's no data available to us from the private sector. The private sector in Fiji is largely outpatient. We've got about 2 hospitals with another 2 that are sort of some inpatients there, some bed days. But because we don't have data from the outpatient, we assume that the patients that are going to outpatient doctors in the private sector are largely disease distributed like the outpatients we have going to our public health facilities. And outpatients in the private sector, outpatients is nearly 20% in number for the outpatients that are seen at our public health facilities. So it's a small fraction. In numbers, not in costs. If you read our report, you'll see that in costs, they are quite challenging, okay? But in numbers. So we can see that the other category here seems to hold a lot more percentage. This is in terms of costs, money, where the money is going. Other also includes communicable diseases. It also includes undefined diseases, okay? Another limitation that we come to at the end of the study. This is by ICD-10. Now what we just graphed it for you. We've taken maternal out right here because maternal, the diseases that are coded under maternal also are largely pregnancies. When women come to give birth at hospitals, they code them under this category. So it largely inflates this category. They're not sick. They come to deliver. They spend 2 days in the hospital, then they go, they're treated as an inpatient, they're coded under that category. So they should be able, they're not really sick, but of course they're using up hospital resources and government resources, but we probably just take them out. So that's the distribution. This is by gender, okay, and I've just highlighted the yellow ones. So we can see probably, if we just take one, neoplasms, which is largely cancer, 71% females, and 29% in 2014, and the same in 2014. So our results suggest that cancer among women is quite high in expenditure compared to males. In expenditure. In numbers, maybe different, but this is in expenditure. How much are we spending? Okay? This is by ethnicity. Okay, again, ICD-10. We can see that endocrine nutrition, I think diabetes sits under here, largely it okay in 2013, and it's still it okay in 2014. Whereas mental diseases had a bit of a switch. 2013, 54% for Fijians of Indian descent, went down to 24% here. Diseases of the circulatory system probably will equal 56-40, 46-51 with kind of even here. Okay. This is ethnicity within a specific group. So within Fijians of Indian descent, we find the highest around disease of the circulatory system and diseases of the respiratory system. And the respiratory is 10% there. For the it's okay respiratory, but you can see the top category, which is not NCD, which is largely CBs, also has some percentage up there as well. Okay, so I told you earlier that not all these categories are NCD, okay? They are largely NCD, but there are disease codes within them that go elsewhere. So we thought, what about we use the global burden of disease? So there is a methodology that allows you, in this one, we simply ran the results by the ICD category, which you saw earlier, which was this one. So there's a column in the database that says they coded under this, they coded. But there's also a column that shows specifically what number under R00 to R99 the patient was coded. And for that, we can use that to map it to the global burden of disease structure here, which has a better distinction between CDs and NCDs, okay? So we thought, let's represent the results by the global disease classification. This is what we get. Outpatient by GBD, 2013-14, you can see NCDs here is high, okay? Percentage of expenditure. Undefined is worrying, so it's, again, another thing we've got to look at. Inpatient, here, you can see that communicable maternal perinatal nutrition conditions are high. So like I said, what we did, remove maternal from that category, and you can see that they go down here. So here the material conditions are in green. The NCDs here are in purple, and over there they are in green, okay? So they've balanced when you take out the material component of it. So that's inpatient by DB. We've only done this for 2013 and 14. Many patients, data quality, of course, incorrect coding of disease. And you know that most of disease coding is done by coders at health facilities. And your coders are not recognized very much as important people, okay? They have very low salaries. Believe me, if you compare it to the other cardboard health workers. So they do the coding, okay? But so we must continue to train them, upskill them, give them a career path, okay? Because any incorrect coding will come from them. Missing data, always an issue. Multiple data sources. In the case of Fiji, we had to use some manual data, we had to use some data from the patient information system, and then some from FIS. Patients with multiple conditions. Our results were coded only using primary diagnosis. But you will understand that patients come with multiple conditions. So someone who is coded with an eye problem could have come with an eye problem because of his diabetes, okay? But we then coded with primary diagnosis. Allocation keys, work in progress, and absolutely no data from the private sector. Conclusion, national health accounts can be a very useful tool for the Pacific Island countries to monitor health expenditure. Why do I say this? Because it presents disease in a holistic view, and it's not like a one-off study. People come and say, I want to cost diabetes, or I want to cost rheumatic heart disease. This gives you the entire picture, okay? 20%. Also, we've seen some results that tell us that, do not ignore other diseases. The whole conversation is about NCD, but other diseases are also pressing and important, and it's showing us a dual burden of disease. And we need improvements in our health information systems. Thank you.
Our last speaker, I invite Ravi to give, and then we should be able to have a few minutes for questions before we have to go for the closing.
Thank you very much, Rosalind. I've been given the unfortunate honor of being the very last presenter after 2 days of policy discussions. So if you have not slept yet, now's your chance. To your credit, I have removed many of my slides, so let's see how we do. What I'm going to do is build on some of the discussions that we've just had from Paula, from Masoud, from Idrish, Wayne. What we're going to do is see from the evidence base, what can we do about NCDs? So we'll talk just a little bit about framing obesity and diabetes. That's where I'm focusing most of this talk, just because I have policy examples to share with you. I want to look at what's called health and all policies. It's a policy approach that's applicable to the Pacific. I'll give you a few examples, and then we'll wrap up. So first, this reprises some of what Paula's already presented to us. We have extremely high, the world's highest rates of obesity prevalence and diabetes right here in the Pacific. We probably have a few economists in here. The World Bank has estimated it cost the Pacific $8 billion a year back in 2012. So that number has likely risen. I think that's not, as Paula was mentioning, that's not necessarily the annual expenditure on NCDs. That's actually what it's costing in terms of lost productivity as well as the expenditures. But it's linked across the board. And this came out in some earlier discussions as well with food insecurity, trade practices, culture, specific characteristics of the Pacific, the small geography, the small economies, and the real resistance to climate change. So essentially, where we are right now in 2016 is that our Pacific Island countries are not well placed to do anything about the Sustainable Development Goals, specifically 2 and 3 related to nutrition, hunger, and health. So what are we going to do now? First of all, we do have a lot of evidence, and the Lancet put out a series of publications back in 2013 focusing on the NCDs, but that evidence has been buried, and we can see why. It's worth taking a look at what we have. These are the infamous mutton flaps that come from New Zealand. Here we can see turkey tails, canned corned beef, spam, not the kind of thing you know, but just as disgusting. So what do we say about this? I think one thing that we should say, we have to be honest with ourselves, the mutton flaps, they taste okay. They really do. They're not great, but they're not god-awful, okay? Anybody who's not a vegetarian has eaten something that looks like this. When you fry food that much, it all tastes the same. And what that happens to be turkey tails, you can get it at Domino's City, it's just a 5-minute walk. I don't encourage it, but it's there. And essentially, here's the story. If I am a mother or a father in Kiribati or Tokugawa or someplace, and I have to feed my family, I've got limited budget, here's something that's going to fill my kids' stomachs. And let's be honest with ourselves, this kind of thing, it tastes good, right? We're fighting our own biology. And there may be some specific characteristics of the people of the Pacific that makes them more prone to disease based on this. Because there's a history of not eating this, so the body is not adapted. Because there may be other characteristics. We don't know, it's speculation. But the reality is, the evidence gets covered up. We're really dealing with this, so what do we do? Health and health policies. It's a policy approach, so I think it's appropriate to discuss it in this seminar. We're looking at a population level, and how do we address health without just sticking to the hospitals or to the physicians? What are we going to do outside of that? Because by the time somebody gets to a hospital or physician, they're an emergency case. So we need to do something else. It stems from 2008, the WHO held a conference on the social determinants of health, and a lot of the thinking that went behind that is now influencing this policy approach. It also goes back to the first WHO conference on health promotion back in Ottawa, and there's an Ottawa Declaration. That in turn came from the Alma-Ata Declaration on health for all. So there's a long history on this. It's creating public policy coherence. And what does that mean? It means that policies should not be fighting each other. Right? We'll talk a little bit more about that. Intersectoral collaboration. That's where it's all policies. So we can look at law. We can look at education policies. We can look at trade policies. We can look at criminal justice, for that matter, and see how does it work together to influence the health of the population. So there's some coordination by the health sector, but the leadership is shared, and we'll see that with a few country examples. What does it mean for the Pacific? First of all, some other characteristics of the Pacific. We have very small public services, right? We're small populations, and the government is necessarily smaller. Some of these big, rich countries can buy all the skills, the budgets, they've got everything that they might want to have. We can't afford it in our economies. But it makes structured use of the limited resources we have. And to put it another way, we already know that the person who is taking care of this issue is also taking care of the other issue. He just has to change hats. Or she just has to move from one desk to another desk because she's the only one there. So we already have the people playing these roles, but they're doing it in a disconnected fashion. If we can start putting together an integrated policy approach, it will help them do both of their jobs or all of their jobs better. Secondly, linked to obesity and diabetes. We know that it's a trade issue. And we had already the example about how Samoa withdrew its ban on turkey tails, those tasty things in the middle of the screen, withdrew the ban in order to get into the World Trade Organization. Not because the World Trade Organization demanded it, but some very large rich countries that were exporting turkey tails to Samoa thought it would be important for Samoa to do that before it gave its consent. So trade is an issue. Low quality of food imports, right? We know that, we can see it. High transport costs, but also the high quality of our fisheries, right? Not necessarily talking about the tuna that's automatically exported before any Pacific Islander actually sees it, apart from the observers. But really the coastal fisheries, or the indigenous and organic agriculture. These are things that the rest of the world is trying to catch up and doing, and it's already happening here in the Pacific. And then lastly, high food price sensitivity, meaning a lot of our families and households need to buy the cheapest food available that's going to fill up the entire family. High price sensitivity is a way of putting it to economists like to talk that way. I'm not an economist, I'm trying to find them. So bottom line is the multi-sectoral approach is very critical. And if we don't do it, if we try to do it as health professionals, we will fail. We will just see more and more people coming sick to our hospitals. So, we already know about this again, right? Here you go, there's the Samoa Latin rewarded. That's the headline number where it went into the WTO. Here, choosing between trade and public health. Does it have to be a choice? Because We need trade to grow our economies, and we need public health so that we can actually enjoy whatever income we get. Over here, this one blames New Zealand, if there's any Kiwis here. Sorry. And so on, right? In Tonga, the taste for fish and vegetables, staples of the traditional Pacific Island diet was lost, right? We have a cultural tradition we can call back on. So there's hope, and there's ways of moving forward. Moving to some of the examples, there's quite a few examples. South Australia's got some very forward thinking there. Chile has some. So you can see there's both partners of the Pacific as well as Pacific-facing countries, Thailand also, that are ready to provide examples and support. New Zealand did it in the context of the Christchurch rebuilding after the earthquake. So there's some different examples there. Finland was a pioneer. They did it because they had a group of essentially adults who were living through the winters and eating very unhealthy foods because that's all they could store through the winter. It was non-communicable diseases, but it was cardiovascular disease related to obesity. And they first pioneered health and health policies in order to address the needs of that community. It's called North Korea, and given that they only have 3 hours of sunshine in Finland, I'm sure they'd be happy to come to the Pacific and explain more. But the EU members have also done it in North America, US, and Canada, mostly at the provincial level, like in Australia. And so that's interesting. National governments of big countries have not done it, but that's useful for us in the Pacific because we don't have to think about hundreds of millions of people. We need to think about something at smaller scale, and so these examples are relevant. Looking at Australia, they focus on transport, education, and food. So one thing we needed, this is in the state of South Australia, they needed a mandate from the head of government, and the head of government bought into it. They understood that it's not just people's individual behaviors or lifestyle. It's not just the kind of counseling a physician or a health counselor can give to you when you show up, right? We're not waiting for you to get 60 to ask your doctor a question. It's actually something that goes beyond. It's affecting what choices of food do you have, or how are you moving around to get to work or to school. So they conducted what's called a health lens analysis. You can also do a health impact analysis or a health audit. There's a variety of different techniques. They're all being developed. The way to think about it is if you want to build a building, you can't just go put the bricks in the ground. You actually have to do an environmental impact analysis because that's been established that we don't want to destroy the environment just to have some private good. We do the same thing now for health. We're just starting it. So we do a health impact analysis. In transport, we will do what's called active transport, making people move instead of just moving people. So that means not just motor vehicles, but, again, this is a South Australian example, bicycle lanes, or finding ways that we can get people to be walking for greater distances, but not so it's inconvenient, to keep people on time. They did a lot of analysis on this. In education, they work with schools, both for physical education programs, health messages, as well as what kind of food is being served in the schools. That is important because for youth, we're setting them up for the rest of their lives. We are establishing what will be the future social norms when we work with children. So it's very important to get the school food right. And then the general food supply. This involved a lot of intensive work, working at the local level, working with towns, administrators, and with shops to see what kind of foods are available. It was led by a senior executive group that included health professionals, but also people from all of these other sectors. And it was linked with several universities, because that universities were there to work alongside the policymakers, provide some analysis about what's working and what's not, and to provide extra input, because policymakers are very much involved in the government administration, and not so much in the academic sphere. So that partnership is very useful in South Australia. Looking at Chile, something very interesting. They worked with law. The police there were cleaning up unlicensed vendors, getting them off the roads. And so what the Health and Health Policies Group came together and said, look, these people are going to come back, we know that, and this is just a way of the police clear them up one time, 6 months later they're back in a different street corner. Why not actually license them and get them to do some healthy foods? So they were both with abandoned stands as well as converting snack stands into healthy stands. And then the Health and Health Policies Group got them licensed with the administration. It required some expenditure because these were very people on the margins of society. You don't have a home, so you sleep under your cart. But you can sell something and make a living so you can keep on buying whatever it is just to survive. This got people on their feet, got them out of trouble with the law, and they are now serving healthy snacks to the population in Santiago, Chile. Legalizing the citrus juice stands. Again, just making things legal. And then, like I said before, working with schools. They worked with, I think, all of the public schools and the majority of the private schools in order to change what is being served there. It's not all a success story. They also had some failures. They tried to tax heavily on tobacco, food, and sugar supplemented beverages, and that was pushed back. But then they again came back and they said, we won't tax the items, we'll simply tax the marketing. So any big sign that advertises cigarettes or that advertises, this is a very good idea. Or the sports venues, when all these companies like to come up and say, we're supporting athletic, we're supporting healthy physical activity, they were taxed if they came from those negative sectors. So heavy taxes on the marketing, nobody had a problem with that. Actually taxing the products, that became a political controversy. So there's innovative ways, the whole people didn't think of it. Of course, it came from a different sector to say, why don't we tax this instead of that? So it's getting people together so they can find the right way of engineering what's in society so that people can make the right choices. Key points. The high-level sustained political commitment. I think we just heard with the NCDs summit that we got that commitment we need here in the Pacific. A core team of policy champions, that's to be developed. We don't actually have that, we don't have that experience. But it's making sure that we get not just serving a health goal of reducing NCDs or diabetes or obesity, but actually meeting other goals, such as making sure that schools are cost effective, or making sure that law enforcement is satisfied with the population on the street. And then doing it so that, by the way, it makes everybody healthy. Windows of opportunity. You can't always do this. You can't just snap your fingers and say, it's time to do it, right? I think we have a window of opportunity just after the NCD summit, and while attention is being focused on NCDs. Evolvement of communities. We know that this food tastes good. If we try to take good tasting food away from people, what will they do? No. When we go for our tea snacks, I confess, I went for those cookies, then the samosa. Finally, I had the watermelon, okay? It's natural for all of us, but we need to be able to make the watermelon available so that we do it. And then adequate funding, we know what's there. Next steps. Focus on capacity building for our policymakers in the Pacific. I think that's something that can be a priority. Getting our universities here. We have USD, FMU here, we have, I think UPNG is also well represented in this conference. Making sure that we can get some research so that we don't just copy, paste, and fail. We see what works, what doesn't, and how do we adapt it to our societies. Involving civil society so that we don't leave out people. We get the communities involved to make sure there's a gender lens as we do all of these new initiatives, because no policymaker can do everything. We need to have multiple voices at the table. Developing partners, and this is a tricky one. We always want to talk about trade and aid, and then they make trade and aid fight, right? And we can't blame them. Canadians are okay because New Zealand is obligated to defend its own exports, legally. They may not want to eat that stuff, they may despise it, but legally that government must defend its own exports. And we can't expect them to change the laws. We have to find a way to do it here. And then finally, and this is for the economists in the room, we have to account for the costs of NCDs. Right? We talked a little bit about that. We'll see just a bit more. Wrapping up. Those of you who were in the fisheries presentation just before tea, you heard this also. We have great stuff in the Pacific, and we pack it up and send it everywhere else. And then what do we bring back? We import the worst stuff from the rest of the world. It is the worst, because if they weren't selling it to us, they would process it and feed it to their dogs. It is pet food, and we eat it, right? Again, why do we eat it? Because our families can't afford much else. We have to change how it's structured. It's not just advising people, giving counseling and things. It's got to change the structure of things. So our income from the exports don't cover the costs of NCDs. They will never cover the pharmaceutical budget. We don't need the pharmaceuticals if we prevent these diseases. The benefits of trade are therefore not being seen by our populations. And so we don't have inclusive growth. I'm picking the things at a conference. Inclusive growth for enhanced resilience. We also have the world's worst rates of diabetes, and they continue to get worse. So we don't have resilience here. NCDs they're critical to this kind of policy context that we're looking at right now. So health and all policies, it's an option, it can be explored. it can enable this multi-sectoral action to stop the obesity and diabetes epidemic so that we're not running these expenses. Preventing early morbidity mortality in working age population. Again, working age population is for the benefit of the economists. It just means people get sick and die, but working age population means something for productivity. So financial viability of our countries. We all know what happened to Latin America in the 1980s, right? The structural adjustment policies, they were forced to abandon social services. Can you imagine what happens to our Pacific households and families and people if we say we are no longer going to support education, health, etc., because we ran up the bills and we ran up the loans, and now we have to pay back donors in other countries? And then finally over here, we need to have an integrated, coherent policy approach. It can't just be more projects coming from the same package of donors and doing the same old. We've got to have an integrated approach. So, thank you very much. There are no more slides, so we did it.